So the next presenting is Dr. Arshi SHIKARI. She will be presenting on the efficacy of low-dose atropine in delaying progression of myopia in the fast and slow progression.
Good evening all. I'm Dr. Arshi Nazir, and today I'll be presenting our research about the efficacy of low-dose atropine, that is atropine 0.01% in delaying myopia progression in fast and slow progressors. So, as has been already predicted by Holden et al., that by 2050, about 49% of the world's population will be myopic, out of which 938 million will be high myopes. So this does increase the global burden of myopia, but something else that contributes to it is the progressive nature of myopia. So due to this, researchers have been going on and on about finding something that could combat this problem, and as a result we have come across various modalities, one of which is the use of topical atropine, and atropine has been used in various concentrations, and out of which 0.01% atropine has been found to be the lowest concentration that retains the efficacy and has also an improved safety profile. So despite its prevalence, the exact mechanism of myopia progression as well as the mechanism of LDA remains unknown. Various studies have found that younger age and baseline myopia have shown to affect the rate of myopia progression as well as a response to the treatment. But there are no studies available that may tell us about whether the rate of myopia progression has any influence on the treatment of myopia. On treatment of myopia with low-dose atropine. So hence the need for our study. Ours was a retrospective analysis that was done in Shirov's Charity Eye Hospital, and our subjects included all children below the age of 18 years who had visited our IOPD from September 2018 to December 2023, and were prescribed with low-dose atropine. We had a follow-up of at least 6 months, and myopia was taken as a spherical equivalent of greater than minus 0.50 diopter, and high myopia as a spherical equivalent of greater than 6 diopters. Exclusion criteria were inadequate documentation, previous use of low-dose atropine, non-compliance or discontinuation of treatment, other treatment modalities, and prior intraocular surgeries. So as far as progression went, we divided the patients into two groups: slow progressors with a progression of less than 0.75 diopter per year, and fast progressors who showed a progression of more than 0.75 diopter per year. So the baseline evaluation, we collected data such as the age of the patients. They were divided into 3 groups: the gender, the family history, birth weight, history of any prematurity. We took measurements for height and weight and presence of any strabismus and amblyopia. BCVA was calculated. We did a cycloplegic refraction. We saw the prescribed glass prescription, the axial length, the anterior chamber depth, the lens thickness, central corneal thickness, and the average keratometry. So once we compiled our results, the sample size turned out to be of 83 children, and the mean follow-up period was 1.9 years. The average age was 10.76 years, and the mean baseline myopia was 7.6 plus minus 4 diopters. And about 45% of the 45 patients had high myopia, and the rest were moderate or low myopes. 49% were female and 51% were male, and fast progressors were 49 patients were fast progressors, and 34 patients were slow progressors. So in our results, we could see that all of the slow progressors as well as the fast progressors, they were not very different in means of the other collected parameters. However, the only significant difference was the presence of parental myopia, and in case of fast progressors, either one or both parents had parental myopia. Again, when we compared the results, it was found that in fast progressors, the effect of low-dose atropine was more. It brought the axial length down by 83% as in fast progressors, as compared to 45% in the slow progressors, and the axial length was brought down to by 72% in the fast progressors, and the effect was not much significant in terms of axial length in the slow progressors. And 12 of our patients, they continued to progress despite the use of LDA, and the common factor within all of these 12 patients was the presence of amblyopia, and all of these patients, they were on patch therapy for amblyopia. So the strength of our studies were that it was the first study to compare the results of in larger population, and high myopia was also included in the study. The limitations were that it was a retrospective study. There was a mixed population of high and moderate myopia. Axial length data was present for a fewer patients, and absence of near work and outdoor activity duration, and shorter follow-up period after the LDA therapy. So the conclusion is that parental myopia is a significant risk factor for fast progression. LDA is an effective first-line treatment in fast progressors in bringing down controlling the spherical equivalent as well as the axial length, and the effect is proportionate to the degree of myopia progression, but somewhere a plateau or a stabilization effect is reached, after which it cannot break down the rate of progression in slow as well as fast progressors. So since 14% of the children, they continue to progress rapidly without any explainable cause, so we can say that a combination of lifestyle modifications, optical treatments, as well as pharmacological methods is necessary for control of myopia.
Thank you.
Thank you.
Dr. Arshi. So did you compare between the high myopes also? You said 45 patients were high myopes.
Yes, ma'am.
And you started on LDA.
Yes, ma'am.
So whether the fast progressors belong to them?
Most of the high myopes were slow progressors, contrary to what has been seen in many of the studies. In our study, the difference was not statistically significant, but most of the slow progressors were in the high myopes, and most of the fast progressors fell in the moderate and low myopia.
So what was the possible explanation for you, because it's going against the odds, having such a high myopia and then you're using low dose atropine and then they are very slow progressors? So what did you, what was the explanation for that?
So maybe some
Are there any studies where such a the contradictory to the usual pattern, whether this has been shown in any study where LDA has been used?
no, ma'am, no.
In
In
high
most of the
myopes?
studies,
Only in
although
moderate.
it has not been compared, but
Is there any rationale in using LDA in high myopes? Now you have to look for it. That you have found that it is stabilizing the high myopes. That's
Yes,
what you are coming to, isn't it?
yes, ma'am.
Okay, thank you.